Hi, this is part 2 of anemia pharmacology, and we're going to cover types and treatment. All right, types of anemia. Now, there's a lot of different ways that we talk about anemia and ways that we classify it. We can talk about the type of patho, in other words, like a nutritional deficiency or anemia of blood loss. We can talk about it by cell size, and by that there's microcytic, macrocytic. That has to do with what your MCV is, which we're going to talk about later. Kind of favorite way to teach it, to classify it, is by the size of the cell, which you recall in the lab work, it's the MCV. And you'll find this on page 892 in your Arcangelo book. This is a really handy picture. Microcytic microcytosis less than 79 shows you the causes. Thalassemia, you can have a low ferritin. Remember, ferritin is what? Iron storage protein. So then you're going to have iron deficiency. Now, you can have a normal ferritin, and then you're going to say, I got a small cell, but I got a normal ferritin. In other words, I'm storing the iron. Well, then you know it's chronic disease or sideroblastic. Don't worry, for the purposes of this class, we're not getting into sideroblastic. You will need to know that for differential diagnosis when you take that. All right, the middle column, I got a normal MCV. So the size of the cell can be normal, but you can still be anemic. How so? Well, in acute blood loss. Like, it hasn't been a chronic thing. Your patient is hemorrhaging. So acute blood loss is going to have a normal cell size, just not very many of them. If you have a normal reticulocyte count and a normal cell size, so you're not microcytic or macrocytic, you're normal, then you have to think, okay, it's anemia of chronic disease. This is classic with kidney disease. You can have this with a high reticulocyte count. Remember, when you see a high reticulocyte count, what's going on? The body is in production and it's spitting out immature RBCs. You see this in hemolytic anemias and in aplastic anemias. You can have macrocytic. That's a big cell. What would make a cell big? Something with that nucleus. The shape of the cell is off. So if you have a high RDW, then you could have either a B12 or folate deficiency, or normal RDW can be the other things, hypothyroid or alcohol abuse. Okay, here's our normal laboratory values. You've got your hemoglobin, hematocrit, MCH, MCV, MCH. Those are going to be your standard in your CBC, the ones above here. These next ones, you have to order separately. Now, if you suspect anemia, you may order some of these things right out of the box. But maybe you're just doing a screening CBC and you see that your female patient has a hemoglobin of 10. That's going to trigger you to get more tests. So then you would get reticulocyte, ferritin, B12, folate. There's other things you can look at, the iron binding capacity, but really, I always kind of, iron binding is not my first thing, because I can, if they're low, if their hemoglobin is low, their reticulocyte is high, maybe low or high, but their ferritin is low. So their ferritin is their intracellular protein. I know their iron binding capacity is going to be high. In other words, the storage tanks is empty, so the ferritin is low, but the iron binding capacity is high because there's a lot of like trees out there just waiting for things to be hung on it, so to speak. Okay, so macrocytic or megaloblastic, they're kind of used interchangeably. You see a high MCV, you got a large nucleus. You've either got a nutritional or an absorptional problem. If you got microcytic, hypochromic, in other words, small, pale cells, that's iron deficiency anemia, IDA. Okay, so let's take a minute and do a little exercise here. What do these labs mean? Your 44-year-old hemoglobin is 10. You already know, like, she's low. Her MCV, 75. MCH 23, ferritin 5. Look at Arcangelo, page 894. And the normals are there to help you figure this out. What's your assessment? Feel free to pause this if you're not sure. Your 66-year-old male, hemoglobin 11, MCV and MCH as follows, ferritin as follows. What's your assessment? Now, if you're still stuck, I got some help for you. His creatinine is 2.0. Now what do you think? Next one, you got a 14-year-old, hemoglobin 11.5, MCV 99, MCH 30. What's your assessment? Are you stuck? Here's another little hint. Folate levels too. I hope you were thinking about the relationship between MCV and what could be going on. Here's some answers. In the first one, it's a microcytic because the MCV is low, hypochromic, it's pale, MCH 23, low ferritin. So you've got iron deficiency anemia. Your next one, the values are there. Normocytic, normal chromic, normal ferritin. However, the creatinine indicates chronic kidney disease, so we have anemia of chronic disease. Here's a question. Why? What's going on? What hormone are we not getting in anemia of CKD? Last one, your 14-year-old. She's a macrocytic, normal chromic. She's got a folate deficiency. She's eating either too much McDonald's, maybe she's a little bit of anorexic. Something's going on there with her diet. Maybe, who knows? Maybe she just hates greens. We don't know. Now, on to our treatment. So for iron deficiency, these are the things that cause it. Something is kind of slowly depleting our iron stores. It could be low diet, poor absorption, or increased iron demands. The most common time that I see this is in truly menopausal, well, perimenopausal women who are having very heavy periods. So this is how you diagnose it. You have to find the underlying cause. Because if it's a male and you see this, the first thing you think is colon. So you got to, do colon cancer screening. So once you've identified the cause, if there's not something cause-wise that you need to fix, then you're going to supplement with iron. Now, there's always a lot of things with iron in terms of how to get your patient to take it. Because if it's oral, as you know, there's a lot of GI problems that can happen. They can take it with food, but that's going to decrease absorption. It's best on an empty stomach with vitamin C, actually, that improves absorption. IV iron is also very helpful. I do have patients that I send over to the infusion center for that. Now, how do you tell if it's working? What's your response? You're going to get a reticulocytosis. What does that mean? Should be visible within 7 to 10 days. The adverse drug reactions, oral, we talked about. The iron, there can be some anaphylaxis, but the concentrations and preps have gotten better. Sickle cell disease, there's a mutation there, and so their hemoglobin is not the normal hemoglobin. They make this hemoglobin S with one little mutation, but it's present in the red blood cell, and it causes stiffness and changes in the red blood cell. So people with the sickle cell anemia, this hemoglobin S, when there's anything stressing the red erythrocyte, whether it's blood loss, oxidative stress, trauma, surgery, the red blood cell is going to lose its oxygen and it loses its integrity, and then the cells get stiff and they can clump. You get a sickle cell crisis and you can get damage to the endothelium. This is the normal hemoglobin on the left. One mutation leads to the sickling type of hemoglobin. So you remember, if you think of that one picture of the red blood cell, the hemoglobin is inside the red blood cell. So when you get the sickle type of hemoglobin, that impacts the shape of the cell. And you have to remember why we need a certain type of shape of our cell, right? Picture of normal hemoglobin and the clumping, the tendency to clump hemoglobin. Treatment, we have a great drug called hydroxyurea. It's used prophylactically to reduce crises. So it increases hemoglobin F, which is the normal hemoglobin, increases it like actually impacts the hemoglobin and the shape of the cells. It actually increases the deformability. So the cells, rather than, going right into that torpedo sickling shape, not, the torpedo is the normal, but the sickle, the kind of curve shape, it makes them a little more deformable, and it stops them from adhering to the endothelium as much. You see your dose there. Anemia of chronic kidney disease is reduced EPO because the kidney is damaged. When the GFR declines below 60 is when we can see this. There's several approaches in drug therapy for CKD, but the one that interests us is there's the EPO, which there are guidelines to govern. You can have a B12 deficiency, which leads to impaired DNA synthesis and a macrocytic anemia. You're going to check by serum vitamin B12. And it seems like adults, as they age, um, they're more likely to get this. It's most often pernicious anemia, which is an autoimmune type of anemia where you don't have that intrinsic factor to kind of scoot the B12 across the GI membrane. So usually we treat this parenterally. It can be IM or deep sub-Q, and also I'm seeing some things in the literature that it can be treated with oral B12, which is becoming more common, but parenteral is kind of the standard of care. We can have a folate deficiency, which again, you're going to get the large immature cells, macrocytic. These are our causes. These are our symptoms, and we treat with 1 milligram daily. So to summarize, we've talked about the function and formation of the red blood cell or erythrocyte. We've defined anemia. We've talked about the causes. We've gone over some key lab values, treatment, and some key definitions. Here are your references, and I thank you for your time and attention.